Dr. Mark Murphy. Thanks for spending some time with me. We're going to talk about sleep today, sleep apnea and sleep therapy. And I have this portion of your website up talking about sleep being this $1 trillion market opportunity. But what I see here is this overabundance of patients, people, humans struggling with sleep deprivation, sleep apnea, yep. And given their airway. And then so we have this massive pool of people who need treatment. And then we have this very small pool of providers providing treatment. So maybe just talk me through the current state of the market, and then we'll dive into how, dentists can get involved and help. But yeah, I'm really curious, just high level, where are we at here with sleep in the market?
I just hope, Rob, people aren't watching us late at night, so they are dozing off. And if they are dozing off, I get a great night's sleep and oxygenate well and everything like that. But there's this term from business that there's a couple of books out on it about blue ocean versus red ocean teeming with blood from people fighting and competitive marketplaces. And the blue ocean idea is there's so many fish in the sea. There's so many opportunities there that there's really no competition. That's this construct of blue ocean. So that's really what the sleep apnea marketplace is. Now listen to this number. There's over 1 billion people worldwide. I just want that to sink in. Over 1 billion people with a B worldwide that have obstructive sleep apnea. In the United States, that's probably, we're not sure of the exact number, but based on the 25% of the people having sleep apnea of adults, somewhere between probably 35 and 45, maybe as high as 55, you see in some estimates, million people. Okay, fine. What's that mean? Well, here's the bad news, good news. You and I were talking before we started recording. Sometimes things are a tragedy, and yet at the same time, they're an opportunity. And so when we look at this sleep apnea marketplace, over 85%, probably closer to 90% of the patients that have obstructive sleep apnea have never been diagnosed or treated, So there's this huge number of people with the disease that dentists can treat. They have to do it in consort with a physician. They have to work with the medical community for sure, and there's all kinds of things to do. Huge opportunity, and there's not very many providers out there. Even though there's a couple 100,000 dentists in the United States, for example, and let's say there's 40 or 50 million patients that need some sort of service like this. Even though there's 200,000 dentists and 100,000 of them have ever taken a course in sleep, there's really only about 1,000 that are actively treating sleep. And of those, probably 300 or 400 that really have sleep-only practices. So you can see the number of providers versus the number of fish in the sea,
so,
blue ocean, is very proportionate.
So it's like 1% of dentists are providing treatment, and you said 25%-ish of the population is suffering.
Correct. That's correct.
So then if I'm a dentist, and let's say I'm seeing 8 patients a day for simple math, that means 2 out of every 8 patients is suffering every day in my practice.
Another way of looking at it, if you're talking about a dental practice and you think that maybe you have a couple thousand patients in an average dental practice, and that's pretty close to the numbers the ADA would provide. 500 of them have sleep apnea. 400 of them at least have never been diagnosed or treated. If you screened for those patients and saw those patients and treated half those patients, 200, and did one a week, it would take you 4 years to work through your existing patient population. And the reason this is a $1 trillion market opportunity for 1 billion patients worldwide is that the reimbursement from medical insurance for an oral appliance is around, it's north of, but I use the low number for all of my estimates, but about $3,000. Sometimes it's 4, 5, 6, but say $3,000. Well, if $3,000 is your average, times 1 billion people, that's $3 trillion.
Almost can't conceive.
No, I can't.
Can't conceive of that number.
We had this thing near us called the Pontiac Silverdome, and it held 108,000 people at capacity. 108,000. I remember thinking 10 Silverdomes would be 1 million people. 10 Silverdomes, 100,000 people. That's, so 10 major cities having a major sporting event on the same day. That's 1 million people. Again, it's boggling. I can think of $1 million, and I can do the math on 1 million a bunch of different ways, but it's really hard to get your hands around 1 billion or 1 trillion.
All right. So massive market, or in other words, a massive epidemic
Oh,
of
yeah.
sleep deprivation, and so I got all sorts of questions. But
So,
before we
yeah,
dive into,
we'll get into the specifics because I can't let you use words like sleep deprivation or not
okay,
sleep because
please correct me.
somebody might
What's
get
the
8
right
hours of
way?
sleep. It's about how much oxygen you're getting. That's what sleep apnea is. It's reduced airflow while you're sleeping.
Okay,
Apnea is and
okay.
hypopnea, reduction in airflow. But yeah, we'll cover that off plenty. Plenty.
All right, but before we dive in too deep, though, let's talk high level. And how did you get into sleep? How long have you been into sleep? I know you've been a dentist for a very long time. Just talk to us about your journey
Over my gray
into
hair.
sleep.
I've been a dentist for a very long time. That's why I have gray hair. So you and I go back quite a ways. Yeah, we've known each other since I was back at Microdental doing lecturing and teaching for them and having a ball. And so you and I both kind of grown up with roots in the laboratory industry. I was a laboratory technician before I was a dentist. But for me, back in 1991, I was teaching at a place called the Pankey Institute, a very prestigious nonprofit education institute down in Key Biscayne, Florida. And I was teaching a TMD course with a guy named Keith Thornton, who is one of the true pioneers, just a marvelous guy, true pioneers in obstructive sleep apnea and oral appliance therapy. He developed the TAP appliance and the company that makes the TAP appliance.
Yeah.
AP stands for Thornton Anterior Positioner. That's Keith Thornton's name. So Keith and I were teaching this TMD course, and he got me interested in sleep. And so I started making sleep devices back in 1991. Technically, for the past 34 years, I've been seeing or treating or doing something with sleep patients. But the truth is, in the beginning, I did that. And then I realized we probably should be working with physicians. We probably should be using sleep tests. We were probably doing things the wrong way. We didn't have adjustable devices in the beginning. We didn't have sleep tests. There were only sleep labs. So there was a lot of things I got uncomfortable with after a few years. And so my level of activity dwindled down to about zero. Fast forward to 2012, I was at Microdental. And in 2012, I was diagnosed as having obstructive sleep apnea. And I made myself an
personal
oral
to you.
Yeah, I made myself an oral appliance, started treating myself. Things were going great. And in 2013, the team at Microdental said, hey, we're going to start making an oral appliance because some dental laboratories are licensed to make sleep devices. They're technically a type 2, a class 2 medical device. So you have to have special licensure and everything like that. So not just every lab can make them, but not like a bite guard. Bite guard's class 1 medical device. So Microdental was going to develop that competency. They hired a team, and a couple of people from them came over, engineers and scientists, and worked with myself and others, and Lynn Liptak and Dave Coons and Sung Kim. Great team of people. Thing on the thinking, smart person engineering development side. I did all of the feedback, animal testing of different devices, and they were going to make an engineered precision medical device that was all going to be milled out of a solid block of polymethyl methacrylate so that it wouldn't leach monomer. It'd be a safer device to use, similar to what they're doing with dentures today, milling it. And so that's what we did there. And in 2014, they got their FDA clearance for a device called the Micro 2. And that device existed inside Microdental for a couple of years. And in 2016, Microdental sold to Modern Dental. And that was a large conglomerate. It was already a large conglomerate being sold to an even larger conglomerate of dental laboratories. But when they sold Microdental, they sold all of it except the oral appliance called the Micro 2. They spun that off as a separate company in 2016 called ProSomnus Sleep Technologies. And I spent 8 years with them in various roles and capacities, teaching, education, helping sales, helping marketing. And we took that company public in 2022, December. And I retired from there in 2023. And when I did, I went to work with a vendor partner of ours called the International Academy of Sleep and Restful Software and Billing, who services dentists and helps them develop these competencies within their practice, helps them get paid efficiently, helps them document the right kind of information to work with physicians and insurance companies and payers to try to increase the number of people that are actually using devices like ProSomnus and other manufacturers make. So I left ProSomnus in 2023. So I've spent the last year and a half here at Restful and the International Academy of Sleep. So now I'm doing some of the same sorts of things in terms of it, but I think I have a different set of tools rather than a device that's great. I have a software and billing company and a coaching competency that's great. So it's good. We're helping increase the number of people who can serve that blue ocean.
For sure. So you're with a company today who helps dentists, general dentists, get involved and be empowered. They know the process, they have the billing mechanism, and they can check all the boxes to diagnose and treat sleep apnea with.
So again, I'm going to be, your spirit's correct, but I'm always going to be careful on the words because people are going to listen to this. We cannot diagnose sleep apnea. We can screen
Okay.
for it. Only a
Screen.
board certified sleep physician, so a physician who's then board certified in sleep, and there's only 6,000 of those in the country. There's another choke point there. You can feel that. Most of those are pulmonologists and neurologists, and a scant number of ENTs and primary cares, cardiologists, but about 4,000 pulmonologists and about 1,500 neurologists make up the bulk of the board certified sleep physicians. Only they can read a sleep test and diagnose sleep apnea. Then a physician has to write the prescription for either a CPAP, which is a mask and a hose and a pump that's going to pump air down your tube, or Inspire surgery, or an oral appliance treatment. So only a physician can write the orders for that, and only a sleep physician can read and interpret the tests and determine the diagnosis.
And a dentist work with those two factors.
Correct.
Yep.
The dentist, then, if an oral appliance is ordered, would be the person who is delivering that. Another fun term to just interject. You're going to learn so much today, Rob, that you don't want to learn, but you're going to. Then you're going to deliver a piece of DME, or durable medical equipment, to the patient. And that's what the dentist job is, like a pharmacist. They're filling a prescription that the physician wrote on behalf of their patient. Only a dentist or an ENT, because they know a little bit about the mouth and stuff like that, but very few ENTs bother. Only a dentist really can deliver or render that service, because we take impressions and bite relationships and we follow those patients up. It's a great opportunity for medicine and dentistry to work together. The problem historically was physicians didn't trust dentists because we weren't playing by the rules. I was one of those guilty parties. Weren't doing things right. Weren't billing medical insurance. We're charging exorbitant amounts for these devices, et cetera, and weren't communicating well with physicians. So they came to not trust us, not trust oral appliances. Fast forward to today, they're really beginning to trust us quite a bit and work together, and the devices are much, much better, much better.
Okay, so I loved the analogy. So the general dentist acts as the fulfiller of treatment, right? They're
Correct.
filling the prescription, so to
Filling
speak.
prescription is a perfect way to think about it.
The prescription itself is written by a neurologist or
By a
board-certified
physician.
sleep.
Any physician can write
By
the
a physician.
prescription, but only a board-certified sleep physician can interpret the test results and determine whether or not the patient has sleep apnea. And we can't make a patient an oral appliance for sleep apnea or snoring or anything else like that unless they have a proper diagnosis from a physician of either having or not having sleep apnea. If they have sleep apnea, we're treating them for the sleep apnea. If they don't have sleep apnea and we want to treat them for the snoring, we can. But we can't treat somebody for snoring unless they have a diagnosis of not having sleep apnea.
Gotcha.
So that's another thing dentists were doing wrong. We were going, hey, Rob, I'll just treat you for your snoring, thinking that we could just treat them for the snoring and not treat them for the more serious disease, but that is illegal.
Yeah, we see these anti-snoring devices on Amazon. You can get one for like $20, and you can manually move your mandible forward. I learned that fancy word, titration, right?
A patient can treat themselves over the counter, but we can't treat them for snoring. That is correct.
Interesting. But it's anti-snoring. It's not a sleep device, because there's probably a little loophole there.
And sometimes the devices look remarkably similar to anti-sleep apnea devices. Anti-snoring devices can look very, very similar, but it's what umbrella do they fit under and who's delivering that service and device. It's crazy.
So I want to talk about the two main categories of sleep devices, the CPAP and then the appliance that you wear to titrate the mandible.
Yeah.
Those are the two big categories. Maybe start there, and I assume most general dentists would get involved with the titration device, or
With your oral appliance.
or not.
With your oral
The oral
appliance.
appliance. Okay.
So let's talk about the different categories. There's three therapeutic ways that involve durable medical equipment, three therapeutic durable medical equipment ways to treat sleep apnea: CPAP, oral appliances, and think about the surgical procedure. You see those commercials for Inspire. That's surgical intervention where they insert a piece of durable medical equipment. They put a pacemaker-like device in your chest. They run some wires up to your hypoglossal nerve. They wrap a little collar around it, and they stimulate your hypoglossal nerve to stick your tongue forward at night while you're sleeping when you have events. So those are the three. They do in the country, in the United States, we'll stick with the U.S., there's about 3 million CPAPs placed every year. 4 million or so sold, some are resales, but say about 3 million new CPAPs placed every year. So think about that 50 million number. We're not treating that many of those patients every year either. And the number's growing because obesity is growing, et cetera. Patient population is aging, all kinds of stuff. So there's about 3 million of those done. There's about 250,000 oral appliances done on an annual basis and about 15,000 Inspire surgeries. So CPAP, huge, 3 million. Oral appliances is about 6, 7, 8% of that. And then Inspire surgeries, maybe 10% as much as oral appliances. But Inspire surgeries are $50,000 a pop. Okay. Oral appliances are about $3,000 a pop. CPAPs are about $1,000 a pop, but by the time you factor in the hoses and the maintenance and everything over a 3 to 5 year period that they're supposed to last, just like an oral appliance, they cost about 2 times to 2.5 times more than an oral appliance.
And the other thing, the bulk of traveling with that darn thing.
And we could go on and we will go on and on, I guess, for hours or at least an hour. But here's the thing: if you give 100 people a CPAP in 1 year, less than 50% of them are actually wearing it. And when they define wearing it, or they define adherence or compliance, their definition in the medical world for compliance is 4.5 hours a night, 5 nights out of 7. That is less than 50% of the sleeping time. In oral appliances, if you give 100 people an oral appliance, 90 of them will be wearing it at the end of a year. And we define compliance as 7 hours a night, 7 nights a week. Inspire, if you give 100 people an Inspire, 70 of them will be wearing it at the end of a year. We'll be turning it on at the end of a year because there's a little turn on button to it. 70 of them, but it only works 68% of the time when it's on. Oral appliances work about 90% of the time when they're on for mild and moderate cases, and a little lower, around 80% for severe patients. CPAP works about 100% of the time. So you have this great treatment. CPAP works like 100% of the time, but patients won't use it. Then you got this kind of crappy, very expensive, patients don't use it as well as you'd like or as often as you like. It doesn't work that great. Surgical procedure. So in between is this new up and coming treatment, which is growing dramatically. The estimates of the CAGR growth for that marketplace are 15, 18% annually. That's huge. At ProSomnus, they grew 35, 45, 50% year over year, every year.
So it sounds like you're in favor of the oral appliance.
Oh, yeah, 100 times,
procedure.
100 times 100, absolutely. Now, it's not right for everybody. There will be some patients for whom CPAP's a better treatment. There's also other non-surgical interventions that aren't durable medical equipment, like losing weight, like sleeping on your side or on your face instead of on your back. For some patients, positional therapy helps. For some patients, getting nasal surgery and clearing out turbinates and things like that, if they have an ENT diagnosis, that helps. But that's a smaller segment, a smaller minority of the 40 or 50 million that we're talking about in the U.S. So oral appliance therapy it doesn't work as well. It's not as efficacious, but it's more compliance driven, more adherent. So because more people will use it, it's actually a more effective therapy. If I gave you a pill for your hypertension, I just gave you high blood pressure, by the way. If I gave you a pill for your hypertension, but made your hair fall out so you wouldn't take it, and the pill was 100% efficacious, it worked 100% of the time, but you only took it half the time, then it's only 50% effective, right? That's math. That's just simple math. And that's the same thing true with CPAP. So CPAP's a great treatment that people can't tolerate, so it's not very effective. Oral appliances are really good treatment that people can tolerate, so it's more effective. It's kind of an interesting way of looking.
So the net positive outcome is what you're kind of walking us through here is you have the efficacy of the device and then the patient compliance piece. So you really sounds like you position an oral appliance as a preferred, not the magic bullet, but a preferred treatment method for many or most cases.
It is, and that's why it's growing so rapidly. The guidelines from the American Academy of Sleep Medicine, that's the medical group, and I'm a member of that, is that patients with mild or moderate kind of should have a choice of what they want for treatment. Severe patients, they think, should try CPAP first because it is so efficacious, it works so well, that if they can tolerate it, that they should go on CPAP. And most every dentist would agree with that treatment modality. So 2/3 of the sleep apnea patients could be treated by choice, and almost all of them would choose an oral appliance. And 1/3 should be treated with CPAP. Instead, today, 9 out of 10, maybe 9.5 out of 10, are getting a CPAP.
Interesting.
Change is difficult.
Interesting. And so I know you had a few visuals to show us and walk us through some important data points for our dentist audience.
I do.
You pull that up and let's walk through that.
I do. So when we think about sleep apnea, we really are looking at this, pandemic kind of billion-person worldwide problem. And it's really a problem that's caused by the structure and the anatomy that we have, and it's made worse by a lot of other things. Now, and let me explain. We're the only mammal that has sleep apnea. We're the only animal that has sleep apnea. There's some other animals that will make a snoring sound, but they don't really snore. The only exception to that is a type of bulldog called a British bulldog. But let's excuse the poor British bulldog, leave him out of this equation for a second. No other mammal has obstructive sleep apnea as a disease characteristic. Why is that? Well, the reason is because when we started to walk upright and extend our heads and vocalize as much as we've done, that's all great stuff for us from an evolutionary standpoint. But it also meant that our epiglottis, which covers and protects our airway, and our uvula, that little thing that hangs down in the back of your throat, separated from each other and left a gap. In every other mammal, those two structures overlap and prevent the tongue from falling back and closing the airway. So when we sleep, we've got this gap where the tongue can fall back and close off the airway, where it's not protected by the uvula epiglottal structures. So when we lay on our backs, gravity, small upper and lower jaws, which our jaws are getting smaller over the last several hundred years. Obesity, we get heavier, laying on our back, gravity. All of those things allow us to add alcohol to the mix, add some other medications, depressants, things like that, cause us to have a restricted airflow. And when we're breathing at night, we're breathing very differently than we do during the day. During the day, you would never snore. You would never lack oxygen. Why not? Well, because my muscles have a certain structure to them, a certain tone, and there's a certain patency to my airway. But at night, you're supposed to be resting and recovering. And in the first half of the night, you're supposed to be in deep sleep, fixing your structural body, your musculoskeletal structures. And in the second half of the night, you're supposed to get a little bit more dream sleep and fix your brain, take out the garbage and all that stuff. And so when you're doing that, you're supposed to be barely alive. That's what sleep is. Sleep is barely alive, keeping your brain alive and let your body rest and recover, and then take the garbage out in the brain. And when we do that, we don't breathe with the same volume we do during the day. We just barely get enough air in and out. Our tidal volume, which is normally large, and our muscle tone, which is normally large, is great during the day. But at night, barely enough oxygen to keep us alive, barely enough tidal volume, barely enough muscle tone. So when the tongue falls back and starts to restrict the airflow, we don't get enough oxygen in, our oxygen level drops. When we talk about sleep apnea and hypopneas, if that happens and you wake up to take a breath, if that happens less than 5 times per hour, that's considered normal. 5 to 15 is considered mild sleep apnea, 15 to 30 moderate, and north of 30, we see over 100 in some patients, more than once a minute.
That's what you're measuring in the sleep test, is how many times they kind of gasp for air?
Yes, either gasp or at least wake up to take a bigger breath. Now, they don't wake up consciously. They wake up just enough to disrupt their sleep and get some oxygen in, because your body is going to try to protect your brain at all costs.
That's a good thing.
Scary to say that 15, 20, 30, 50, 70 times per hour, once every minute, once every 2 or 3 or 4 minutes, you're actually waking up and it's disrupting your sleep. And when it does, it doesn't wake you up by tapping you on the shoulder, gently stroking your cheek and asking you to wake up. It sends you a bolt of lightning called adrenaline. And so we also see in these patients the heart rate rise, see the blood pressure rise. We see a sympathetic surge of chemicals in the body, so that you can see these common diseases in the slide that are associated with much higher incidence in patients with obstructive sleep apnea. A patient with sleep apnea is 23 times more likely to have a heart attack at night when they're sleeping, 5 times more likely to have a stroke, 4 times more likely to die of COVID. So it's very, very serious. No one dies of sleep apnea. You die of the heart attack or the stroke or the hypertension or some other metabolic functionality that's broken down. You die of those things that were made much worse by obstructive sleep apnea. That's what's so sneaky shit about this disease, is it's not the cause of death, so it doesn't get the attention that a cancer does or a heart attack does or a stroke does. But if you're 23 times more likely to have that heart attack, I want to pay attention to that. Judge Antonin Scalia, the Supreme Court Justice, was found in his bed, died of a heart attack with his CPAP on his bedstand next to him. He never put it on that night. He had some alcohol, gone to bed, and in one of those sympathetic storms where his heart rate's jumping to 110, 120, 130, his body thinks he's pushing a car out of a snowbank, but he's laying there in bed trying to rest. But the lack of oxygen caused the same sort of response that you would when you have a heart attack pushing a car out of a snowbank. That's crazy.
That is crazy. So if I'm a dentist and I'm like, okay, I see an opportunity to help my patients how do I get involved? I would guess a minimum is just know how to refer a patient out to someone who can treat them, but then maybe a dentist wants to get into it themselves. Like, what's the process of a general dentist getting involved in treating sleep?
So Rob, if I can start with, why they also might want to get involved. I mean, you might want to get involved to help the patients. That's a noble cause. You might want to get involved because, you'll have healthier patients. That's another good reason to get involved. You might be involved like I was because I had some personal attachment to it, having been diagnosed in 2012. Another reason you might want to get involved is because we've had a lot of headwinds in dentistry. In dentistry, we have been challenged financially. It's shocking, and this is not my data, by the way. This is not Mark Murphy's conjecture. This is the Health Policy Institute from the American Dental Association. Tells us that roughly since 2005 till now, we've had about a 20% decrease, 1% per year over about 20 years in the average dentist's net income adjusted for inflation. I want you to think about if somebody took 20% away of your income overnight, you'd say they stole something from you. But if we took it away 1% per year, you might not notice. Practice expenses are rising and reimbursements are going down. And so what's happening is dentists are working harder, seeing more patients, doing more procedures to try and hold serve. And they're being challenged by that primarily because of the role of dental insurance. Because dental insurance isn't really insurance. Insurance is when a third party takes the risk for a catastrophic loss. So if you totaled your car, if you needed open heart surgery, if your house burned down, that's a catastrophe and you need coverage for that. Most dental insurances stop at about $1,200 or $1,500. Most dental insurances don't cover the catastrophic loss. They cover the everyday maintenance needs that a patient has. I'm not saying it isn't a good thing. It's a great thing. I love it that people have dental insurance. They can get their teeth cleaned a couple times a year, maybe get a couple fillings or a crown done once in a while. But if somebody has a catastrophe, which insurance is supposed to cover, like they need implants all on four, they need a couple of bridges, they need new dentures, insurance disappears. Insurance was first invented in 1957, the year after I was born, and it covered then, let me think, about $1,200, about the same as it covers now. If they had adjusted that for inflation and kept up, dental insurance would cover about $8,500 to $9,000 on an annual basis. And then it would be real insurance. So there's this discussion, this language we use about insurance, third party, patients want to do what's covered by insurance, dentists want to participate with insurance, PPOs are discounting it. It's a mess. And what happens is reimbursements are slowly going down. And so over the last 20 years, it's been hell to pay for dentists in terms of this reimbursement model. So my question really is, what can you do about it? And if you are going to try and do something about it, you want to do something that you know you'll be successful at. And so we've tried to add, in the average dental practice has tried to add placing implants. They've tried to add Invisalign. They've tried to add, let's call them ancillary procedures to their armamentarium, to their portfolio that allow them to make more money. Doing a veneer, doing a crown is usually more profitable than doing a filling or doing a cleaning. Totally get that. So sometimes we can adjust our mix of services. But with sleep dentistry, there's an opportunity to really blow all that away. And that's what's kind of fun to talk about. Now, to your question, how does a dentist get started? What would they do? You're right. Every dentist since 2017 has the responsibility. The ADA wrote a position paper in 2017, which was a resolution which was passed by the Board of Dentistry in 2017, so 8 years ago, that we should all be screening for obstructive sleep apnea. No one has to treat it, just like I don't have to do periosurgery. I don't have to do third molar extraction. I don't have to do orthodontics if I don't want to do any of those things. But I have to at least examine my patient, recognize those problems, and refer them out. So the same is true with obstructive sleep apnea. In obstructive sleep apnea, it's simply a matter of getting some good training someplace, learning basic sleep physiology, and then learning the 4 parts of the treatment flow for a patient, and that's getting patients, getting them tested with a physician, and then getting them treated, whether it's an oral appliance, whether it's CPAP, whether it's Inspire, whether it's positional therapy. We don't choose the treatment, the physician does, but we of course fill that prescription, as you and I were talking earlier, if the oral appliance is chosen. And then in order to do any of that successfully, you have to have really excellent documentation, otherwise insurance companies aren't going to pay. And you have to have a billing partner that creates a predictable reimbursement workflow. And then you have to understand what you have to do to manage the challenges. What's interesting, just to stay on that financial part of it, just a tiny bit more, is this is the data, again, from the Health Policy Institute on what the average dentist does today, about 780, let's just call it $800,000. The average dentist does about $800,000 in collections, works about 1,750 hours. That is, like it or not, none of our listeners are average. They're all above average and all good looking. But
Yep.
that's $457 an hour, including hygiene, and a little over $300 an hour, not including hygiene. If I saw patients and made an oral appliance, my reimbursement for Blue Cross in network in Michigan was $24.56 and 40 cents. I have some policies that pay more, some policies that pay less. Some
So this is for one appliance?
Some policies that pay $6,000. Policies are all over the map. I bill the same fee every time, $6,200, $6,200, $6,200. And if I'm in network, I'm going to accept these different payments. I use this one because it's fairly low, but it still makes my point. If I use $24.56 as a reimbursement, I'm going to spend about an hour and a half with that patient. I will have a material lab fee of $600 or $700, of course, but I'm going to produce $1,638 per hour. That's about 5 times what I can do as a general dentist. I'm not suggesting that the reason you'd want to get into sleep is because you can make more money. I am suggesting that if you decide you want to, you got to screen these patients anyhow. If you decide you want to treat these patients, you can get trained up on it. Making the devices is actually easy. And it's very fulfilling emotionally for you and your team to help these patients. You get all kinds of kudos, thank yous from them. They feel like $1 million. Almost all of them give you some positive feedback. And oh, by the way, you get paid 5 times an hour what you can get paid doing dentistry. It's redunculous. This medical reimbursement for this medical procedure, which has a medical solution, which involves a dental appliance, which is delivered and rendered by a dentist, is, I think, the most productive activity you could do. Think if you did 5 devices a week, and that's 20 a month. That's a very proficient sleep practice. 5 a week, you could do that in a day. You could do that in less than a day. But let's say it took you a day. If you did 20 a week, 240 a year at $3,000 a pop, that's $720,000, and your overhead is way less than a dental practice, which is usually 65 to 80%. It's hard to have an overhead that's even 50% in dental sleep medicine. So you could have a $720,000 practice working 1 day a week and keeping more than half of that. That's crazy.
That's incredible. I mean, I look at that $3,000 number and I think of, okay, the implant and crown, maybe that's around, placing an implant crown's around $3,000. It's probably taking you way more than 1.5 hours to
and a much higher
treat
lab
that
fee.
patient. Much higher lab fee. Or a clear aligner case, roughly maybe about the same, 3, 4, or 5 grand, but you're going to spend a lot more than an hour and a half.
And $1,200 on your aligners.
Yeah, exactly. So obviously you want to have good motives to help people, but the revenue per hour is really compelling here.
Yeah, it is. And it's,
really
again, it's not the reason to do it. It's the reward for doing it. I would argue that if you did it just for the money, that would show on your face. It would show in your relationships with your patients. And so it would be critical to not be that way. But coming back to, the earlier part of our discussion, there's 200,000 dentists in the country, roughly. 100,000 of them have taken a sleep course. About 7,500 have ever made an oral appliance. So think about that. 7.5% of the dentists who've ever taken a sleep course ever made an oral appliance. 3.75% of all the dentists ever. 1,750 approximately, and that's a pretty close number, have ever successfully billed medical insurance. 1,750 have ever billed medical insurance for 1 device or more. And 350 to 400 of that 100,000 who've taken a sleep course have developed a dental sleep medicine practice where they're doing 10, 15, 20, 30, 50 devices a month. We have a member of our restful iOS community who does about $6 million a year in dental sleep, multiple locations, uses associates and stuff like that. Very, very innovative business model. Not for everybody, not for me, but it's a great business model. But the idea is, if I were to do a couple days a week of sleep, I could have a $1.5 million, $2 million sleep practice, and we see that, and be doing 20 devices a month and not be killing myself, not be stressed, excellent reimbursements, patients loving me, easy to work with, low overhead. I could rent space from another dentist even instead of having my own office. So we see dentists, when you look at this 350 to 400, you see a lot of dentists coming to sleep, and if they get it and they figure it out and they work with if they have good billing and documentation and reimbursement pathway, they get it and they get it figured out. And a lot of them sell their dental practice and move into sleep only. And then they take the cash from their dental practice and sit on that for 3 or 5 or 10 or 15 years, do dental sleep medicine, and that asset grows. You see, each dentist has two things going on for them with their dental practice. One, it's an income stream. I love that. It was a great income stream for me. I sold my practice for a percentage of my revenue a long time ago and banked that and let it grow. That's great. That asset is the second part of a dental practice. Getting a chance to monetize that early and yet still create an income flow that's superior to what you're doing as a dentist usually is an incredible design opportunity that some people might opt for. It's really cool.
Yeah, what I see here is this duality of a tragedy and an opportunity. Right?
Tragedy and opportunity is 100% correct. 100% correct.
Unbelievable. I had a question on the testing piece. I've heard of, going to the sleep lab. Like I've had a friend that went to the sleep lab and did the overnight sleep study. But do they have some at-home sleep devices now where you can take something home and monitor your own sleep and so you don't have to go to a sleep lab?
So remember the slide where I said you first got to get your patients, then you got to get them tested, then you got to get them treated,
right,
and you got to do good billing and documentation. So in the testing box, if you will, in that box, prior to COVID, home sleep tests were on the rise. And prior to COVID, probably we had just gone from 90 to 80%, and maybe we're on our way to 75% of the tests being done in a sleep lab.
Okay.
After COVID, when we came out of COVID, 95% of all the tests are now done at home.
Yeah, COVID is a great instigator.
And they're as easy as a little ring that you wear, or a little wrist thing with a thing on your finger, or just a little chest piece and a little thing that goes over your nose. There's different complexities. There's different types of sleep tests, different levels, and there's a whole science to that you need to learn if you're going to do sleep. But 95% of them are done at home. And that's both because it's cheaper, and all the payers are looking for a less expensive way of getting something done. It's also very efficient and comfortable for the patient. But on top of that, if the question we're asking about the patient is, do they or don't they have sleep apnea, a home sleep test works just fine. If you're worried about, and I'm going to use a term you mentioned earlier, sleep latency or insomnia or narcolepsy or multiple sleep latency or restless leg syndrome or any of those kinds of things, then you need an in-lab sleep test. It's a much more sophisticated test, and people are watching you sleep, but that's only about 5, 6, 7%, less than 10% of the time do we see in-lab sleep center tests done. Some countries like Belgium, for example, we get a lot of great research out of Belgium because all of their sleep tests are in-lab. They only do PSGs, polysomnograms. And they only treat moderate and severe sleep apnea. They don't think mild sleep apnea is big enough risk. And there's a lot of questions about that. In the United States, we treat mild, but Medicare, if you're over 65, Medicare says, we're not going to treat you if you're mild. You're old enough, you're not going to die from this, unless you also have one other comorbidity or illness. So if you have hypertension, daytime sleepiness, diabetes, history of heart attack, then we'll treat you because they know that it's all math. They know that that'll save them more money. The cost of admission and readmission of a patient to the hospital is so high for cardiovascular events. That's why even CMS, Medicare, will pay for Inspire surgery, even though it doesn't work very well, because it's just a math equation. It's risk and reward. They pay $40,000, $50,000 for surgery, but they reduce that patient's cost of being admitted and readmitted to the hospital.
So as a general dentist, I go through some training, I get connected with a physician. Can I order the at-home test for the patient, or do they have to go see the physician in person first to get started and start the testing process?
So in 45 states, the dentist can order the test but can't read it. So they can get the ball rolling in 45 states. Most dentists don't do that, though, even though we can. Most dentists refer them to like a telemedicine at-home sleep testing company that is oral appliance friendly. So like, there's a company called Rest Assured or sleeptest.com, West Coast Diagnostics, these companies that I'm very comfortable with, where I see a patient, I say, Rod, based on this thing called a stop bang, based on your upward sleepiness scale, you're at high risk for sleep apnea, but we don't know for sure until we get you tested. So let's go ahead and get you tested. And so I send you to them. They'll have a telemedicine physician visit with you. They'll mail you the test. You'll wear it for a couple nights. You'll mail it back. They'll read it. They'll send me the results and a prescription for an oral appliance if that's appropriate, and we're off and running.
Okay.
So sometimes you don't even need a local physician to work with. It's great to develop those relationships because if you really want to grow the sleep practice, you start with treating yourself, your friends, and your family. Then you move to screening and treating your patients in your population, but eventually you will run out of them 3 or 4 years.
Yep.
So you have to be planning on developing relationships with your local physicians so that the pulmonologists, the neurologists, the ENTs, the cardiologists are sending you patients to get treated.
So then, as a general dentist, is there a mode where I could treat patients where I screen them, I facilitate a test through with a third party, and is there a path forward where the patient doesn't have to physically go see another doctor? They could just get treated remotely, and we get the physician remotely.
That's what I was describing. That's what I just described was this telemedicine where you refer them to a telemedicine portal where they meet with a dentist in a telemedicine visit. They don't see them physically, but they do have to see a physician. They do have to be diagnosed by a physician, and a physician
in person. Or
no,
remotely?
Telemedicine. And then a physician has to write them the prescription. And all that can be done, and that's what I was describing, was a telemedicine loop with Rest Assured, West Coast Diagnostics, and sleeptest.com.
Well, I'm just thinking through the eyes of an entrepreneur of like, I have this patient who I want to keep my relationship with, right? And so as a dentist, I can be the provider and facilitator and not require them to physically go see a bunch of other third-party providers, right?
That's exactly what I just described. Yep, exactly.
I love that.
Now, but you still do want to develop physical visit relationships with local physicians at the same time. Why? Because you're going to run out of patients. If you've got 2,000 patients, you take a couple, 3 years and treat them, you're going to run out of patients that can say yes to getting an oral appliance, and you're going to need a pathway for new patients. You could market to the general public. You could market to your local dentists who don't want to do sleep. Those are good venues as well.
Business.
But really, working with local sleep physicians is, if you look at that 350 to 400 that have real sleep practices doing 15, 20, 30 devices a month or more, every one of them has developed strong relationships with their local physicians. That's part of the pathway. That's easier to do today than it used to be, for sure.
Okay.
For sure.
I want to talk about titration and the effect on the condyle and the bite, right? It's one of my burning questions. We used to own a lab, and then we did some design work, so I know a little bit about occlusion and bite. And should a dentist be concerned or a patient be concerned that titrating the jaw is going to mess up my bite or cause TMJ pain? I mean, just walk us through what happens when you wear the device, and then how you sort of reprogram your bite and what's going on there.
So start with old style custom but shitty devices made out of cold cure acrylic with metal ball clasps and things like that, were large and bulky to wear, and you'd have to push the mandible a lot further forward to treat the patient. As soon as you start to increase the dose and push the mandible further forward, titrate the mandible further forward, you're going to increase the side effects you're going to see from that treatment. Today, with printed nylon devices, with milled acrylic devices, with milled Evo material devices from ProSomnus, things like that, the devices are so much smaller. The amount of advancement in titration is significantly less, and you get that patient into a therapeutic position. So we see significantly less side effects. Plus, if we have the patient hold that position and go forward in a straight line instead of a crooked line, because we've made the device in software, we can control things far better than manually. We have a digital process that uses artificial intelligent design, robotic manufacturing. The precision is much higher. We see fewer side effects. If you gave me 100 TMD patients of all kinds mixed together in the normal pattern of mix, and I treated them with an oral appliance for sleep, if they all had sleep apnea, 95 of them, their TMD would get better. And in the other five, and in the other 5, we would just discontinue treatment. Bruxism, we know now today, is a precursor mandibular movement of the mandible coming forward, trying to open the airway in most patients.
Really?
We didn't know that 10 years ago, 20 years ago. That's in the literature, well documented, with magnetometers measuring mandibular movement prior to an event. It's the mandible coming forward and an airway problem. So should we treat these patients orthodontically? Should we do orthodontic surgery? Of course we should, but it's much easier to do that in kids than it is in adults. So in adults, I'm just going to pull their jaw forward and let them sleep there. Also, if I'm not using ball clasps and I have good fit and retention, teeth will not move. Modern retainer-like devices fit so well, they act as retainers. Not the old ones, not with the ball clasp, not the cold cure acrylic, but the newer ones fit like retainers, so we don't see tooth movement. We do still see bite change, because when you sleep for 8 hours with your jaw sticking forward like that, the condyle is filled with fluid, and you have to squish that out in the morning. And some patients don't do a very good job of squishing that out and getting their bite back. And if they don't, their bite will change because of mandibular condylar repositioning due to long-term fluid intake into the joints, which becomes a little bit more fibrosized. So we always make them a couple of little things that they can use to remind them where to put their teeth in the morning to get their bite back, called morning aligners, morning occlusal guides. And that has reduced the incidence of bite changes dramatically. So wet mouth, dry mouth, yeah, we see that. Joint pain, extremely rare. TMD problems, almost never. Bite changes, yes, we do have to worry about that because that's dependent on the patient's compliance in the morning after they've slept all night. So we do still see that sometimes in patients that are non-compliant, but I always like to make a big deal in my consultations with patients about that so that when it does happen, because it still will happen once in a while, not very often, it's their fault, not my fault. But if I didn't warn them of it, it's my fault and I'm making excuses. But if I made them 2 morning occlusal guides, trained them how to use it, and they don't use them, I can't fix that.
So I wake up at 6 a.m. How much time on average does it take me to get my bite back?
Doesn't work that way. Doesn't work that way. No. Everybody's different. And the further forward you go, the longer it will take to get your bite back. It might take 30 seconds. It might take 30 minutes. Okay.
Okay.
It'd be unusual for it to take 30 minutes or longer, but some people wake up and their bite comes back almost instantly because they're not very far forward. Some people who are further forward, I don't use a MOG at all. I get up in the morning, I take my appliances out, and 15, 20 minutes later, my bite's back. But some people have to actively use these things and play and squish and pulse and do some exercises and get their bite back every morning. And they can check that. They don't have articulating paper, but they can check that with a piece of floss, biting between their teeth and make sure they can catch it. No big deal. Most patients do not have a bite change. So really,
most do not.
If we look at 10 years ago, side effects were common and expected. Today, with precision oral appliance therapy, side effects are rare and very uncommon.
Well, that's good. How important is, what do you call a bite repositioner that you wear in the morning to?
There's a lot of different names for it. The official name from the American Academy of Dental Sleep Medicine is the Morning Occlusal Guide. MOG, M-O-G.
M-O-G. How important are those? Would you recommend prescribing them on every patient or just
I
relative
make
to
I make two of them for every patient. One for them to use and one as a backup when they lose this one, because they will eventually lose one. And then I'll order them 2 more and charge them for them.
Okay, so you highly recommend these and you provide them as a standard of care.
It's not like I recommend, it's standard of care. Standard of care is to make an oral appliance that repositions the mandible accurately. Standard of care is to make them a morning realigner. There's lots of different types. I use a milled one that's very, very accurate and precise. They cost me like $58 for 2 of them, but that's far better than the patient's bite changing. You still have patients who don't wear them, who don't notice, and they come back 6 months or 2 years later and they think their bite's changed, and it has, and now they have a posterior open bite, which, by the way, is not a problem usually. Rarely is that a problem. Almost always it bothers their dentist that they have, because I don't have any patients there. I don't do any dentistry. I'll have them for 20 years. But so it usually bothers their general dentist, but the patient eats, talks, and chews just fine. They don't really miss, because it's not like they're open. It's not like they're open half an inch. They're open, 2 sheets of Meinol,
Yeah.
They can still chew.
Are we wearing this appliance for the rest of our life? Are there any indications of patients getting healed or growing out of it?
It's prescribed for the rest of your life, just like CPAP is. But theoretically, a patient could lose weight, change some of their habits, change their sleep position, and maybe get out of therapy. But that's not common. Usually it's a lifetime prescription for CPAP, oral appliance, or hypoglossal nerve stimulation surgery.
And so if I'm wearing this device for the rest of my life, you had mentioned the appliance itself can be retentive, meaning sort of functioning like a retainer, and it's also preventing bruxism at night. Right, so there's some other positive...
your open airway is what really prevents the bruxism. But yeah, it does protect the teeth because it's got some material over it. But it's really that open airway. You've lost the if I made 100 devices for 100 bruxers, 5 of them would still brux, maybe 8, okay, but not 10. And so I've got one patient, lovely guy. He's moved a couple times, and we've just mailed him new appliances. He's broke his device 3 times. That is extremely rare. He's broken the posts 3 times. On a very, very strong Evo device. And that's just because he's a monster bruxer, like a cow, side to side, and he just bruxes no matter what. But that's very rare. Usually you open the airway, they stop bruxing. So I think he's got something else going on that, he can't control and I can't control, and he seems to be able to break anything you put in his mouth.
Wow, okay. So if I'm a general dentist, I want to get started, where do I go?
You should go to dental school, because you said if I'm a general dentist so many times, you should go back to school, get 1 more degree.
It's a Freudian slip. Where do I go? What would be the next step for me to start the journey?
Thank you. So there are a lot of good places to get clinical education. We certainly have one of them. The restful software and billing, the predictable reimbursement model that we have, and nobody has anything quite like that. We have portals into all of the insurance companies. We have this guided documentation so you don't miss things, so you do get paid predictably. And all the billing companies charge about the same, but we have incredibly better results. The clinical education comes with that software for us. We give people 12 weeks of coaching. We have different programs they can attend. But again, I'd be lying if I said we're the only one that can provide that clinical education. The clinical education is easy. How do you take an upper and lower impression, precise impression, scan? How do you scan a bite at about 50% of the patient's protrusive range of motion, protrusive, retrusive? I mean, I could teach you that in 30 seconds because, you've got this strong dental background. But I could teach a person off the street that in 30 minutes how to scan and take bites, right? It's not a big deal. That's not hard. And it's not that hard to teach an auxiliary how to do that for you, or how to deliver those devices, or how to adjust those devices. The mechanical parts of the clinical part are easy. What's hard is getting paid. That's why dentists don't do this. The challenge, the reason more dentists aren't doing sleep, is they get into this and they go, this is exciting, let's go. And then they can't figure out how to get paid by medical insurance. And so we've had several generations of software that are out there and billing companies that are out there. And when the founders of this company built this software, it was with the idea of trying to correct some of the mistakes of the previous builders of software and billing competencies. And so this software gets you paid. There's a law in all 50 states called the Clean Claim Act. If you provide a perfect insurance claim, it has to be paid within 30 days. And that's what this software makes you do. You cannot submit a claim that's mistaken. It's very, very hard to trick the system. And then we have portals into all of the insurance payers all across the country so that we know that Aetna in Michigan requires a 4% desaturation rule, and Aetna in Wisconsin only a 3%. And you need a physician in Connecticut, but you don't need a physician's notes in Arkansas. And all these little differences. And so the software knows this in real time. And so the software makes sure that you put the right things into your SOAP notes so that when you submit your claim, you can attest to everything being right and getting paid. And so that's why this software and billing reimbursement model has been so successful of late and is kind of disrupting the industry, sort of like ProSomnus with their precision oral appliances disrupted oral appliance manufacturing. ProSomnus, think about it, in 2014 gets an FDA clearance for a device. They have $0 in revenue. 11 years later, they're the largest manufacturer in North America.
That's incredible. I mean, it just shows the efficacy, and obviously if they're growing, the patients are happy, doctors are happy, and so they continue to prescribe that. So it sounds like the treatment, or go ahead.
Yeah, so we have a software and billing competency that comes with coaching. A lot of people get into that, and then they decide they want more coaching and training, so they sign up for a 1-year program. There's a 3-year program, but most people opt for getting started or the 1-year program, which is fine. If somebody emails me at mark@iaos.com, mark@iaos.com, and tells me that they're listening to this podcast, we'll get them to one of our blueprints, one of our 2 or 3 day programs that we have, sometimes with hands-on, sometimes with over the shoulder. We've got different kinds of programs. And we'll get them to one of those at a very affordable rate so that they can see what all of the education looks and feels like, see what the software looks and feels like, and then they can make a better decision. It's a great way for them to, go through a software demo or a strategic needs assessment and figure out what's right for them.
Yeah.
Happy to do that.
I'll make sure to put your email in the YouTube notes and the posting notes so people can find that. It sounds like the screening, the scanning, the process seems pretty simple, understandable for a general dentist. The billing is the pothole in the road that has discouraged many, and it sounds like it's often they're missing details, so they get a claim rejected and they don't get paid. And so your software ensures that their ducks are in a row and they get paid for their time in treatment.
100%. We make sure that you've checked all the boxes, crossed all your T's, dotted all your I's, so you do get paid. If you don't find a solution to that reimbursement model, then you've got this clinical skill, and the only time you can do it is for cash. When a patient's desperate, they hate their CPAP. So when we said there's 7,500 dentists that have made an oral appliance, 1,550 that have ever successfully billed medical insurance, that huge gap of numbers down to the 350 to 400 that are really doing sleep is because those people are left doing 1 or 2 a month, which is fine. If your goal is I want to do 1 or 2 a month and I want to do it for cash, live happily ever after. If you say I want to do 1 or 2 a day or 2 or 3 a week, and I want to build a business model around this, you have to figure out how to get paid by that third party. You have to work with insurance. You have to work with physicians. There's just no
And
way.
it's medical insurance. It's not dental insurance, right? It's medical insurance. So
yep, and that's a whole different beast. And so you will have to pay a third-party medical billing company, Restful, exceptionally good, but you could pay Restful, you could pay one of the others. You're going to pay $300 a claim. You're going to pay some percentage. You're going to pay something for each one of those claims, and it's just an embedded cost. When you get really big and you're doing, let's say, 20, 25 devices a month, that's 300 devices a year. If you're going to pay $300 a claim for 300 devices a year, that's $90,000. Now you might think about hiring a medical biller to work in your practice, like you have a dental biller to work in your practice, but not till you get to those kinds of numbers. And many of the big, busy dental sleep medicine practices still use a third party for all of their billing just because it streamlines things and takes care of it. But know that when you get large enough, it might make sense to figure that out yourself. But till you get to 25, 30 claims a month, just pay a third party to do it.
Makes sense to me. Yeah. I mean, and you're on the hook and you're motivated to help me, my I's and cross my T's so that I get paid and you get paid, right?
How about this? This is what's fun about Restful combining with the iOS, these two merged companies. We're motivated for you to do devices and you to get paid so I can get paid. And we're actually motivated to help you learn how to do more devices. Why? Because we'll make more money and you'll make more money. We'll all be happy. More patients will be healthier. So that's why we've embedded this. We've got 12 weeks of coaching that comes along with everybody that signs up, even for the software. So that gets them really a jump start in the beginning of getting going. So it's been really successful.
Super cool. Well,
fun.
Dr. Mark, I've really enjoyed our time together. I felt like we could for sure keep going, but thank you. Any final words to say as we wind it down?
I would just say this, that in our lives, I'm old. I'm 68. I'm going to be 69 this summer.
You're young.
Thank you, but I don't feel young. So when you realize that the runway in front of you is so much shorter than the runway behind you, you really start to change your perspective on stuff. And I heard this comment from a psychologist once that rings true for me, and it's why I'm in the role I am now. It's part of why I left ProSomnus and retired from there and came over here. We're all going to have regrets at the end of this game. When we're laying on our deathbed, we're all going to have regrets. I want them for everyone to be regrets of things that you did that maybe didn't work out, or you wasted time or made a mistake or something like that. But when you ask people on the deathbed about their regrets, they didn't talk about those. They talked about regrets about things they didn't do.
Omission. Yeah.
Correct. And so I would say we have to screen patients anyhow in our practice and refer them somewhere if we don't want to treat them. Mechanically, it's easy to treat. Yesterday, it was harder to figure out how to get paid. Today, with Restful, powered by iOS, it's very predictable to get paid in a very timely fashion. And so there's really not a good excuse to not treat these patients. Fear of TMD or bite changes is so small today with precision appliances. Everything is pointed in the direction of this growth to continue for the next 10 or 15 years. Neural appliance therapy, it's an incredibly great time to get started. Reach out to me and I'll help you.
Thank you, Dr. Mark.